Fantastic. I believe we are live. We are joined here by Michael Leonard and Dr. John Lee today. And what we're doing something a little bit new, is we're live streaming to both LinkedIn and YouTube at the same time. And the reason we're double casting is because we put all of these broadcasts, these conversations. So we've had some great conversations in the past with people like Janae Sharp on provider burnout, Edward Marks on information technology strategies, John Glasser just last week on medical informatics, and this week, Dr. John Lee. But these conversations that we're having, we want everybody to be able to be involved, take part, use that understanding, whether it be for your role within a healthcare system, or as you're just learning about how healthcare patient engagement and artificial intelligence and machine learning play into that. So on YouTube, all of our broadcasts are available for free. You can binge watch content on healthcare, IT, and patient engagement and patient marketing, especially as the stuff on Netflix just isn't as good as it used to be given the pandemic. We're putting out good content for you. So just wanted to put it out there. Check out our YouTube to see these conversations if you missed them. But ultimately, we're really excited to be having this one. Mike Leonard, just by way of background for the people on the call, Chris, I work in data science for market-facing and healthcare-related data science projects and predictions. Mike Leonard, he's the CEO of Symphony RM, and his role has been to use learnings from telecom, from finance, enabling next best actions in all these other industries, bringing that same kind of thinking, bringing that same kind of action-oriented analytics, prescriptive analytics into healthcare. John Lee, Dr. John Lee, he got a very interesting story, very interesting background about how he started as a physician, but then transferred, being frustrated with a lot of the gaps and challenges that he was seeing firsthand in the emergency department as a physician. Seeing all those gaps and challenges has led him into medical informatics leadership to be able to make a difference and make a change that bridges those gaps and provides a better healthcare experience overall. So we're going to jump into some questions and conversation with Dr. John. And while we're doing that, I just want to encourage you to shower us with all the likes and comments and things like that. We like that. We need that encouragement. And at the same time, it's not three talking heads. The reason that we do this on these live streaming platforms is so that you have that direct conversation. You can ask questions directly to the leaders and experts that we bring in. So say hello, ask questions, and yeah, if there's anything that interests you, we're going to bring it up. We're going to have a conversation with you. And look, we have our first comment already. Kathy Rhodes, happy Friday to you too.
Thank you, Kathy.
So John, I can't be doing all the talking here. I think that it's really curious. So we've had just with regards to the frustrations that led you where you are today, the work that you've been doing with Edward-Elmhurst, and now you're taking on a new role with Allegheny Health Network. Really, just we've had past conversations on things like provider burnout. Janae Sharp is a great example of a conversation we had there. But I'm curious about, before we really dig into the informatics angle, what were the challenges and frustrations that you saw early on, especially with the socio-technical gap? What were some of these challenges? Like, could you talk about just your story on what got you started down the path that you're on right now?
Well, I think there were two parallel streams. The first is just from a practical perspective. I was identified as the doctor nerd in our group. And so when we implemented an electronic system in our ED, I was sort of the natural choice to dive in. And I probably dove in a little bit deeper than they thought I would dive in. And I got really down deep in the weeds and helped with configuration and whatnot. So that gave me a very deep understanding of how these systems work or don't work. But then the parallel stream was that I remember being a young emergency physician back in '99 when IOM's to Error is Human report came out. And being a relatively fresh physician and being, I would say that in retrospect, fairly typically overly arrogant. I thought the report was a bunch of hogwash, and it was just a conspiracy to try to buttress trial lawyers in suing physicians. But then fast forward, as I've done some of my administrative time, and I started actually looking at some of the systematic things that occurred in our system as once I got to my role as a CMIO, I realized, and then I actually went back and read the report, that they weren't talking, and the title is very appropriate. They weren't talking about bad doctors doing bad things. They were talking about bad doctors and nurses and or good doctors and nurses and other healthcare workers doing what they could, but unfortunately and inevitably making mistakes because they are human. And that intersects then with where what we're trying to do with information technology. And I think ultimately what they were trying to accomplish with the HITECH Act back in 2009 to infuse data, technology, and information into our healthcare systems, which were largely still paper-based at that point. And people recognized that because they were paper-based, all that information and data was being locked up in paper and not flowing to the people that needed that information. Now, you could quibble and criticize all the different things that went wrong with meaningful use and the HITECH Act, but ultimately, I think that's what they were trying to establish, and that's what I think led me to what is kind of my obsession on how I approach my job now, is to really solve that equation where you have all this information out there, you have these people who need this information to deliver care or even be a patient, and there's this gap in between that stuff is not flowing.
So thank you for that story and that background, because it really shed some light on the conversation. And just to dig a little bit deeper into the gap that you're mentioning, where there's the technology, but then there's the people on the other side and the actions and things like that they need to take. How would you define the socio-technical gap? Like what would you say that is, so that we're all on the same page, we're all talking about the same thing as we progress through the conversation and some of the things that you're working on right now?
So I would say that a meaningful use in the HITECH Act is a grand strategic example of the socio-technical gap, where theoretically, if you digitize stuff, then you make it that data and information more fluid and able to be delivered to the people who need it. But we all know that did not happen the way that we had fully intended. And on a more sort of mundane level, an example that I often use is drug-drug interactions, and particularly heparin and aspirin. Heparin causes bleeding. Aspirin causes bleeding. When you give them together, up pops an alert that says, hey, both of these drugs cause bleeding. Do you really want to give these together? Well, if I'm a cardiologist and I'm taking care of a heart attack patient, of course, I don't want to see that alert. That synergy between those two medications is what I want. So you have this technology and the information and the data saying, yes, these two medications theoretically do cause bleeding, but in certain situations, you do not, or actually in most situations, you do not want to actually fire that. But you want to be more nuanced about it, because rather than having it just be a binary fire or not fire decision. And so what you need to start doing is infusing things like, has the patient's hemoglobin gone down? What's the patient's platelet count? Are you a cardiologist? Is the patient a heart attack patient? Is the patient's primary diagnosis a gastrointestinal bleed? And then you start infusing all sorts of additional data features into this, and it no longer is this binary on or off. It's, well, it is an important interaction, but you have to consider all these other things. And most systems now have not been able to incorporate that nuanced line of logic. And when you start pulling all that stuff in, that ends up being data science. That's essentially what we're talking about with artificial intelligence, so that the system knows that the patient is coming in with a heart attack. The person who's ordering it is a cardiologist. I do not want to fire this alert to this provider because the other data surrounding this clinical situation warrants that even though this is a drug-drug interaction, it's not something that is appropriate to make somebody else aware about. And so then you multiply that out times, I don't know how many millions or billions of other similar sorts of decisions and data points that exist in all of our healthcare systems. That's the problem that we're trying to solve. That's where the technology has to be bridged with how things actually work in the real world, the social piece of it. And I think ultimately data science and artificial intelligence is going to be the solution to that.
Wow, yeah. So that really paints a clear picture of where there are far too many decision points, far too many pieces of data. Basically, I like to use an example of looking at an Excel spreadsheet. As soon as there's more than 3 or 4 columns that I'm having to personally use to make a decision, it becomes completely impossible for me. So that is an example of just the thinking of where those kinds of use cases, machine learning type use cases, become meaningful. Mike, any thoughts on that in addition to what John said?
No, I actually, what I really liked, John, was the specific example you gave. Maybe for me, part of it is starting to think about, John, you're on the front line. The drug-drug interaction in the different settings, primary care versus cardiologist. Do you have, as you think about it, AI is about predictions. Do you have 2, 3, maybe 4 predictions you think would be most valuable if people could be using data to help physicians, help them do their jobs better, faster, easier? What are the things we could really be helping with?
Well, not specific ones, but just broadly, I think the number one thing that physicians complain about in our current environment is information overload, which is in essence what we were dealing with before and what I think the conversion to EMRs was supposed to solve. Unfortunately, I think it actually contributed and added fuel to the fire. But at the same time, what it did was laid at least a foundation upon which we could use things like data science then to filter out all the stuff that we don't need. I think the natural inclination in this first generation, this first iteration of the first wave of large EMR implementations was to just throw everything at the physicians. The problem is that information and data delivery was really, really insufficient. There was stuff in paper notes that nobody ever saw. So then you delivered all of that to them, and then it's even worse information overload. And you can't find the wheat from the chaff, the needle in the haystack. And what we need is data science then to be able to filter all that stuff out and make sure that the haystack is much, much smaller so that needle can be found by the physician.
John, let me, if you don't mind, a quick follow-up to that, because I agree 100%, and I like the way you said that. One of the things that we found is, there's a lot of companies trying to deliver patient 360, and it makes a ton of sense, right, that you would want to aggregate all the data about a patient into one place. Ton of sense. The problem is with just what you just said, which is if you take all that data and then make it available to every user, the user is overwhelmed with, okay, I can see all this data about the patient, but what I really need to know is what should I do? So that was the inspiration in other industries for next best actions, which is the data science steps in crunches
Sure.
it for you and suggests, here's the 2 or 3 things. The challenge I've seen in healthcare is building the trust that the data science is doing a good job, right? That I trust the data science. I'm going to look at the next best actions instead of going and looking at all the data underneath them. And the other challenge is in healthcare, the data is just so big and so diverse that eventually if you can't see all of it, you may find a piece of data or two that you think would have led to a different conclusion than the data science came to. Could be that the algorithm's still evolving and isn't ripe, or could be that the algorithm was looking at a bunch of data you didn't see. How do you build that trust in the system? How do you get providers and everybody at health systems comfortable?
Yeah, so one of the things that I think has been way overblown and is something that we probably should not spend as much time as we do on is explainability, which is a very hot topic in data science and artificial intelligence, particularly in some of the more complex models. But if you take the concept of some sort of magic black box, but really, really good algorithmic model, if it works, people will use it. To use a different an analogy in the real world that we use on an ongoing basis, there is an antiemetic, a medication that prevents nausea called Zofran. We're not really quite sure how it works, but we give it out like candy because it works. We have some general underpinnings of how it works. We kind of know, but we're not absolutely sure that we actually know how it works. Or to use a more prurient example, we are not entirely exactly sure how Viagra works. We know some of the physiologic underpinnings, but I think the market has shown people are willing to use it because it works. So as long as people understand, I think, some of the general underpinnings of what is data science, and they don't need to know the exact algorithmic contributions to what exact features and in what proportions and which decision branch points caused a particular decision to be made. If they know that it works, they will be fine with it.
Thank you. And while we were talking, we got a ton of good questions from the audience that I wanted to go over. Some of them are kind of lightly addressed, but most importantly, I wanted to give a shout out to Jennifer Velchek. She says hello, just in case you didn't see that.
Yeah, Jen and I used to work together. I'm glad to see her face.
Also, the Dr. Nerd comment resonated. But here's something an interesting question. It's kind of tangential to what Mike was just asking, but it gets specific. This comes from Joe Schmid, who is the Chief Technology Officer where we are. Of course, you met him. Yes. But he said, I'd be interested in hearing John's perspective on how health systems are integrating multiple sources for use with data science. What investments have already been made in this area and what are still coming up? And really the question behind that question for anybody watching is there's so much data out there. There's so many sources. How do we know how to connect and make sense of it all? What's going on inside the health system to make sense of upwards of thousands of tables in various places that data could live? So
I think there are two elements to that. I think just from a basic housekeeping perspective, you have to have a single place to house this. You have to have some sort of data warehouse, or you can't be looking in multiple places to find the data that you need to power these tools. The second element, I think, is that the data that we have in healthcare is so unbelievably dirty. There's all sorts of crap in our healthcare data that really is not only irrelevant, but also makes you think leads to incorrect conclusions. A perfect example of that is something called the Glasgow Coma Scale and the SOFA score. The Glasgow Coma Scale is a measure of how alert you are as a person. And then there's that is one of the features that contributes to something called a SOFA score, which is a summation of how sick you are as a patient. And this came up relatively recently as we were going through some of the COVID crisis. As we were doing this calculation of the Glasgow Coma Scale and feeding into the SOFA score, we realized that a lot of patients were getting Glasgow Coma Scales of 3, which is the lowest score that you could get. But that was because the patients were paralyzed and sedated because they were on a ventilator. The Glasgow and is not a true reflection of the patient's neurologic status. So there's patients who've been on ventilators for any number of days or even weeks who have Glasgow Coma Scales of 3, and that unnaturally suppresses the SOFA score. So that sort of dirtiness in the data exists all over the place. And it also includes things like, a hot topic is having patient remote monitoring at home. But anybody who knows anything at the hospital knows that a heart rate on a monitor, even in the hospital, has all sorts of variables and artifact, and it's entirely unreliable unless you fold that into some clinical relevance and an understanding of, as a nurse, I see the heart rate monitor going like this. That means that's all artifact. Now, if it goes like this, but the patient is comatose and they have a history of ventricular fibrillation, then this thing means that the patient's about to die. So it's that sort of understanding and clinical context that is missing in a lot of the data that we receive that would feed into these data science models. And what you have to do is you have to actually clean the data so that when you're calculating the SOFA score, you exclude all the Glasgow Coma Scales after the patient got sedated and paralyzed, or that you do some sort of pattern recognition and join that with if the heart rate is going like this and the patient is walking around, then no, the patient is not in ventricular fibrillation. And it's that sort of cleaning that needs to be done to make those sorts of data all that much more powerful for feeding into these engines and algorithms. And the analogy that I've been using a lot is, I think many of us have heard the adage now, data is the new oil. Okay, so the problem is that we have like really bad crude oil right now. Nobody would think of taking crude oil and dumping it in your car and expecting it to run. What we need is a refining process. You take that crude oil, send it to the refinery, kerosene, jet fuel, all sorts of tar, and out another product is gasoline, which then gets shipped out. And that is something that you can actually use in cars. And that sort of process is what we need to do with data to be able to feed into the engines that we think will actually help our healthcare crisis.
Other types of non-EMR data. So there's obviously data from payers. You can now buy third-party data, right?
Sure.
It would give you information about potential socio or social determinants of health. Right?
Sure.
You get wealth, employment. You can get and you can get user data, right? Health risk assessments and surveys. Customers seem to be showing a huge willingness to volunteer data. How do you think about other data to enhance and augment the EMR?
So I am personally biased in thinking thinking that those data are just as dirty, maybe not quite as dirty as healthcare data, but they are dirty. But ingesting that and joining that all together goes back to what I was the data warehouse point that I was talking about. And I think what Mike was trying to intimate is that healthcare organizations have not done the hard work of taking that stuff and actually incorporating it into their data warehouse. I think we see some claims data into our clinical data warehouse. We see some like pharmacy fill data, but in starting to see some social determinant type data, but all this other sensor data and many of these other things that you've described really just have not happened again. But I think part of that also is that I'm wearing a Garmin watch. How do we normalize that with Fitbit data? So there's a lot of cleaning processes that have to occur before we actually industrialize that.
So one thing that came in from the audience, and I think that you've done a good job demonstrating the amount of cleaning and the amount of work that it takes to make data relevant. Actually, one comment that we got, it came in from Tracy Scott. Data needs clinical relevance to be most useful. But of course, there's a lot of work that goes in with the cleanup and processing of that. So you have a good perspective in understand being part of and leading teams that do that. But Jen Searles pointed out that there might be a generational gap in people that might not have been exposed to all these data-driven use cases. And it's a curious question on, from our perspective, we know the amount of cleaning that it takes and have a perspective on when data is giving us signal versus noise. But I'm curious if you're seeing any kind of a generational gap where certain positions have different perspectives on the data.
No, I'm actually not. And I think where I think we can make inroads, and I've been trying to push this with some of my artificial intelligence physicians who are interested in artificial intelligence colleagues, is just like we teach biochemistry and we teach anatomy and physiology in medical school, we should teach data science, or at least the underpinnings of data science. Because just like biochemistry gives us insight onto what the Krebs cycle does for cellular metabolism, I don't remember all the details of Krebs cycle, but I kind of conceptually understand the different principles and how different medications or disorders can interfere with that and cause problems. So in the same way, I think we need to have people have a basic understanding of data science so that they understand some of those basic things, so that they understand where an algorithmic output could have come from, just generally. And I think it just needs to be part of the educational process.
We got another really good question. I think it'll take a couple of minutes to answer.
Sure.
Do you have a couple of minutes past the hour to continue?
Sure.
Okay.
Just a few.
Okay. So this question is related to people's acceptance of data or understanding of data or access or usage ever since COVID-19 kind of hyper accelerated the efforts that we need to focus on. So the question is, with COVID-19, has this digital divide widened or narrowed from the provider perspective or the community perspective?
I think certainly in the community perspective, and I think that's been talked about ad nauseum. Not so much from, I don't think from the provider perspective. Just generally speaking, at least from on the clinical front lines, it really hasn't changed that much, other than the fact that we're wearing a lot of PPE. But in terms of the actual digital front face that we encounter on a daily basis, it has not really changed that much. It has actually impeded some of the things that we wanted to do, because so much of our energy has been directed towards trying to fight COVID. But from the perspective of the providers, it really has not, I don't think.
I love the way that you worded that in terms of, hey, this initiative, this event, this pandemic has kind of taken over the roadmaps, taken over a lot of the things that we wanted to do. And another really good comment just came in. about the idea of making sure providers learn data science. I agree with that too. In terms of data literacy, I think there's a difference between a leader or a provider who has a sufficient amount of data literacy and the types of decisions they're enabled to make versus ones who don't. And it's on us as leaders to bridge that gap as well. One thing, but getting back to your comment on what the pandemic has done to roadmaps and the things that you might have wanted to do originally, but might have gotten derailed. It just gets me to thinking about how you're taking on a new role right now. You've been with AHN for about 2 months now. So I thought that this would be a good opportunity to help others who are newly leading initiatives or have different things that they're trying to that they're trying to push to bridge their own socio-technical gaps. How do you take inventory in your new role? How do you decide what's needed and what's urgent? Like how do you decide on how to work with other leaders on what initiatives to push forward?
Well, I think what I've done is, in large part, the time that I've spent here so far has been just listening and hearing where are the gaps, at least heuristically from the perspective of the administration or the clinical end users. And then where people in our profession can help out is that we can take those gaps, those places where there are deficiencies, and think up technical solutions to bridge those gaps, so that if there is a problem with a particular clinical outcome, then think up some sort of decision support tool that is elegant, that people would actually use and understand that actually is helpful for them, rather than just another pop-up that is bothering their workflow, which is a very common phenomenon.
And could you dig a little potentially into the past and maybe your previous experiences, and there's something new that we need to enable for our end users, enable for our providers, and kind of how you bridge that gap, and like, is this another distraction for me, or like how you ultimately prove the value to get them to go along with it?
Well, I think one of the stories that came about from my previous organization is that we had this thing in our system called a preference list, and it was built by an analyst when we went live. And the very minute that we went live and I was watching a physician use it, I realized that it was built wrong. It was built incorrectly. Well, it was built technically correctly, but there was all sorts of content in there that was missing. In particular, just even changing something, a display text for a physician for a particular order is, I realized, was going to be tremendously helpful. So that day, I just rebuilt all the preference lists on my own, because I knew what a physician would want to see. And it took me, it was laborious, but it wasn't an overwhelming amount of work. And that piece of engineering and build, it still exists to this day. And the thing is that my colleagues, most of them don't even know that I did that. And that's the way that these systems is how we should approach these systems, that the good stuff that is the good stuff should be completely transparent to the end user, that it is something that's good. It should be just there, and it should match with how they think and approach their workflow.
Well, I want to thank you for sticking on with us for just a little bit longer and taking care of these questions, because
Sure.
What you're elucidating here, I mean, we're all on the bleeding edge. Like these problems that you solved, especially seeing how that preference list was working and how it wouldn't work for your physicians internally. That's not something that you could Google. That's something that required an intuition and understanding of the business, and some actions to make sure that you were doing it right. So just wanted to thank everybody for sticking on with us and just sharing some conversations and thoughts with Dr. Lee. Great comments been rolling in. Especially, I think there's a lot of positivity around this concept of data science education in medical school, medical curriculum. I think it should be in business and healthcare administration.
Sure.
Actually, they should be teaching data science in middle school.
I agree.
Yeah.
I agree.
But again, thank you very much for sticking on with us. And if anybody wants to get in touch or follow you anytime later, what's the best way they can reach out to you?
Through LinkedIn. I have a LinkedIn page. I think it's or on Twitter at JSLeeMD.
Great. And any closing thoughts, Michael?
Yeah, I just had two things. John, I can't thank you enough for today's discussion. This was awesome. The thoughts on data science were great, actually, and figuring out, because I think data science does help providers scale the amount of people they can take care of, in addition to taking better care of the one in front of them. And Chris, I want to thank you too. These things over the last couple of months have been fantastic. So thanks for keeping this going. I enjoy being on them, but even more, I enjoy being watching other people talk. So thanks for doing this.
Well, hey, we're trying to be like the little tip of the spear, the tip of the glacier for learning. So we're putting this stuff out for free. Everybody can have access to it, and anybody who wants to do an intro to data science course or anything like that, hit me up. I'll be glad to walk you through that. So again, thank you, everybody. Next week, we're going to be digging into value-based care. We've got Nick Bassett from Castell, which is the value-based arm of Intermountain Healthcare. And he spent his career in enabling value-based initiatives, doing the analytics for value-based initiatives, all the way to the networking with outreach departments and other stakeholders in how to make value-based care work. Because honestly, if you don't have that kind of guidance, then eventually you hit a wall in what you're capable of doing with value-based care. So Nick's going to get into the specifics on running those types of programs. But thank you very much, and we're going to go ahead and end here.